Hi everyone, welcome to the next episode of the Kids Cancer Therapy Toolbox podcast. Our guest today is Dr. Wendy Allen-Rhoades, a pediatric oncologist. So my first question is, what inspired you to pursue pediatric hematology and oncology?
As I was going through my training, I decided to do pediatrics because I felt that to improve health, people were more willing to do things for their children than they were for themselves. They were more willing to make changes to keep their children healthy. Whether or not that's true, I don't know, but that's what I thought at the time. And then as I was going through my pediatric training, I really liked the complexity of medicine. And so I knew that primary care pediatrics was not going to be the thing that I chose to do for the rest of my life. And so I started gravitating towards the specialties that were more complex. And I decided on oncology because I liked the science behind it. And I also really liked the sort of longevity of the relationship that you can build with your patients. So it's not that you see them one time and then never see them again, but the relationships are years long. And I felt like that kind of fit with what I wanted to do in medicine. So that's kind of how I landed there.
That's really interesting. I never thought about parents are more willing to care for their kids.
I don't know if that's true, but that's what I felt at the time because there's a lot of chronic health conditions in the adult population that may be best suited with lifestyle change and other things like that. But that's exceptionally hard to do. Myself, as a person, it's exceptionally hard to change habits and patterns. But I think when you're trying to take care of somebody that you love so intensely, you will do some things that you might not have done for yourself. So that was just my perception. I don't know if it's true or not, and adult medicine physicians may argue with me, but that is what it is.
Yeah. So what does your workday look like if there's kind of some regularity, I guess, to that? And do you think there's any parts that are overlooked?
Um, my day has no regularity to it. So what I do right now is I see patients a day and a half a week in clinic. And so I will see new patients, patients that I'm already taking care of. And then I do a lot of second opinions because I'm at Mayo Clinic and a lot of people come here for second opinions. And so that's just like what I would consider like a regular doctor day. Um, and so on a regular doctor day, it's, seeing them, seeing how they're doing, ordering chemotherapy, looking at scans, changing treatment plans if we need to. But then the other part of my life is more at the sort of research and institutional level. So I run our clinical trials in pediatric oncology. So I'm meeting with our research team, checking data, auditing charts, making sure that people are enrolled correctly, making sure that the data that is going into the trial database is correct to the best of our knowledge. We're screening patients to see if they're eligible for trials. I'm working to, bring new trials to Mayo Clinic so that we have more offerings for our patients. So that's a large part of my job. And then because I'm here at Mayo Clinic, it's a really big adult hospital. And so making sure that I understand what can be leveraged from like the larger group that I can bring to pediatric oncology takes up a lot of brain space for me. And then I have like a bunch, like a smattering of other administrative responsibilities. I run our outpatient clinic, which is not just pediatric oncology, but all subspecialties. So just making sure that pediatrics has a voice and a footprint in Mayo Clinic is a large part of my job. So the actual like oncology part is the days that I'm in clinic and then sort of around the research and then um, about 5 times a year, I work on our hospital service where I'm there 7 days a week, 24/7, taking care of the patients that are in the hospital, either for chemotherapy, for planned admissions, or if they're having complications or symptoms that need management in the hospital.
Wow, that's a lot.
So there's not a lot of regularity. Every day is a little bit different. Every night before I go to bed, I have to like look at my schedule to see where I'm supposed to be the next day because I never know. So
Right.
it's crazy, but I love it.
Would you say there's one treatment that's the most common?
So when I talk to families about how we treat cancer, I kind of lump it into three, maybe four main things. One is we can give medications for cancer, and that is generally called chemotherapy, but there are hundreds to thousands of different chemotherapy options that exist in the world, and only a few will be relevant to each cancer type. And then we can do surgery, which I don't do surgery, obviously, but our surgeons do surgery to cut out tumors. And then we can use radiation, which is high energy X-rays to kind of burn the tumor, for lack of a better explanation. And then sort of the new category is immunotherapy. So using the body's own immune system for cancer surveillance, detection, and elimination. That's kind of chemotherapy, but it's a different flavor of chemotherapy. So I always tell families like you can poison it, which is chemotherapy, you can cut it out, which is surgery, you can burn it, which is radiation, and then you can try to use your own body a little bit better, which is immunotherapy. So most childhood cancers, there are very few that we can just cut out and leave, but there are some. So that's one option. Most chemotherapy, or most childhood cancer requires chemotherapy, which is medications either taken through the IV, by mouth, or sometimes into the spinal fluid. And those are medications that kill cancer cells. I would say over 95% of patients with childhood cancer will need some sort of chemotherapy. And then sometimes we use radiation in childhood cancer, but not always. And we try not to if we don't have to, because radiation has its own profile of side effects that are not super ideal for growing children. But if we have to use it, we have to use it. And then immunotherapy is really exploded in adult oncology, and we're getting some progress in pediatric cancer, but it's not as well developed as it is in adult oncology. But the most common childhood cancer is pediatric leukemia, and we now use immunotherapy upfront in pediatric leukemia. As of like a year and a half ago, a trial was successful, and now everybody gets this immunotherapy called blinatumomab upfront in pediatric cancer. So we're making progress, but there's a lot of room to go for immunotherapy in pediatric cancer.
That's great. So when you talk to parents and children, how do you make sure that they understand all the information that they need to know?
That's a really good question. I am a very simple person. I grew up on a farm in the middle of North Dakota. And so I try to keep things super simple, sort of just the way I explained it to you, like cut it out, poison it, burn it. I also find that there is a lot of confusion and misinformation around cancer. What is cancer? What causes cancer? Um, and I think that's like the very beginning of where I start my conversations with families. Adult cancer is very different than pediatric cancer. Adult cancer is a consequence of growing old, and having changes over time. And those changes over time can be just because, you're now 85, or it can be because you stressed your body by, too much sun exposure, smoking, alcohol. Viruses cause cancer, and you're exposed to those as you go through life. But pediatric cancer is really more of like a developmental problem. You have to go from, two cell, a sperm and an egg combine into a zygote, and then you have to take that two-celled structure and turn it into a whole full-fledged human that comes out small and then grows into an adult. That is a very complex biologic process. And sometimes in that process of trying to grow into a full human and then grow into a big human, some mistakes happen. And our body should recognize when those mistakes happen in those cells, but a lot of times they don't, because cancer is sneaky and it tries to find ways to hide from our immune system so that we can't recognize those cells that are bad. So a lot of times it's getting a little bit antiquated, because not everybody has watched this show anymore. But I used to explain it in the old Willy Wonka film with Gene Wilder, where the squirrels would check the nuts and then they would say bad nut and they would get rid of it. That's what our body should be doing, is finding that bad cell and then telling that cell to die or killing that cell. And when that doesn't happen and then those cells continue to grow, that's what happens with leukemia. Um, my families, we, at the beginning of therapy, we meet weekly for months. And so it's not a one-time conversation. Do you understand everything that I told you in this hour-long visit? But it's repeated exposure and repeated education. And I have a huge team that helps me. My nurses do a lot of my education and explanation. And so it's not something that they have to understand all at once. It's just probably too much. It would be like me trying to learn how a car transmission works. Like, no, thank you. I'm not going to learn it in an hour. Like, I don't understand mechanics. And so it's just, we have to keep repeating, keep educating, and people come up with questions later, and it's a constant education cycle. But my goal on that first visit is to make sure that they understand the basics and where we need to go, and then the rest will kind of sort itself out as we continue on with that education.
Right. So, what are some of the challenges of cancer survivorship and how can we/parents support their needs?
Yeah, so cancer survivorship for childhood cancer survivors is multifaceted. I think the first thing that comes up that is very unexpected for people is how scary it feels. Um, if they're a teenager or a young adult, they feel this, but if it's a younger child that, is just kind of doing what 5-year-olds do, then it's the parents. But you have a problem in your child or in yourself that is life limiting and potentially life threatening. And you work for, 6 months to 3 years to get rid of that problem. And you have constant contact with your medical team. And then suddenly you're in survivorship and we're like, you're doing great. You don't have to come back for weeks to months. And it feels like you just got poof, jumped off a cliff. And you're like, but what do I do if I don't see you every week? And it feels very scary. And it causes a lot of anxiety. And so that is number one. People think that families should be grateful, happy, and relaxed when they hit survivorship, but there's always the fear that something is going to come back or something's going to go wrong. And it's just very hard. It's a very hard time of the treatment cycle. So I try to warn people as we're getting close to the end of therapy, like nobody wants their kid to get chemotherapy or have surgery or need immunotherapy, but it's necessary to get them back to health. And so as we start getting closer, I start to have these conversations with families like, this is going to feel weird. It's going to feel scary. We're still here. You're going to have days where you doubt everything, and that's okay. So that is one part of it. Some people move through that and it gets a lot better. And some people don't move through that as fast or maybe ever and kind of live with this trauma of what's happened to them or their child, and they have healthcare PTSD basically. So there's a lot of work that has to go into that as we get into survivorship. Um, from the medical side, there are a lot of things that happen. I consider not consider it's well known, but I explain childhood cancer survivorship as we've asked this small body or this young body, even if you're 17, you're still young. We've asked this young body to process a lot of medications, to go through a lot of things, and just like people that are 85 who have experienced life and gone through a lot of things and their body has been stressed out by things, that makes us age. And time makes us age. And so we know that childhood cancer survivorship is really accelerated aging. So they age faster than their brothers and sisters and peers who have not gone through cancer. And so we have to look for all of these things we call late effects, which are really, sometimes they are direct toxic effects from what we've done from radiation or chemotherapy. And other times it's like they're developing heart disease earlier, they're developing cataracts earlier or glaucoma. And so you may be getting these things at age 30, 40, where you would normally get them at 65. And so it's teaching them that not to ignore your body. If people are telling you you're too young to have these things happen in you, it really might not be true. You really might be having them, and to keep an eye out for it. So there's lots of things that we monitor for, but there are things that happen that we are not specifically monitoring for. And then the other part of survivorship is just making sure that the cancer doesn't come back. That's like what people are most worried about, but I also worry about this psychosocial development, getting kids, back on track socially with their peers, school, education, work, employment, if they want to find a partner, all of these things are impacted by what they've gone through. And then the late effects, and then, oh yes, also we're watching for cancer. So it's kind of three things all rolled into one that happens over the course of years once you finish your therapy.
Yeah, that's a lot.
It's a lot. It's so much. Survivorship is actually very tricky. But we as a medical community, um, we have to continue to work on it and take care of them because we can't just create survivors and then like just let go of them. Like we have to make sure that they're okay and they're actually thriving and not just surviving. Surviving is necessary, but it's not sufficient.
Right. So, how do you imagine the treatment of metastatic rhabdomyosarcoma so that this disease is uniformly survivable?
That's a Charles Keller question, isn't it? Metastatic rhabdomyosarcoma, not all metastatic rhabdomyosarcoma is created equal. So there are some patients that have fusion negative metastatic rhabdomyosarcoma that have better outcomes than not if they're younger. The group that I have been focusing on for the last couple of years is an extraordinarily hard group to treat. I hope that in the future, a lot of times we can get metastatic rhabdomyosarcoma into remission, which means that we have no evidence of active disease in their body based on the imaging scans that we have. The hard part is keeping them in remission. So I am hopeful that in the future we have something, probably in the immunotherapy realm, that we can give as sort of a maintenance to try to help keep their bodies active to surveil for cancer so that we can prevent that relapse from happening. We know how to make it go away. And most of the time it works, not all the time. It is a super aggressive disease. But we cannot keep them in remission. And we've tried the trial that just finished that I was in the study PI of. We added chemotherapy maintenance to it, and those results are not out yet. They should be out later this year. But I think chemotherapy, we can't give chemotherapy forever. There's cumulative toxic effects that affect people. And so we can't keep people on chemotherapy forever. But there's a plausible future where we can keep people on an immune booster or immunotherapy for a longer period of time to try to keep these people in remission. So that's what I hope is coming down the road. And that's what I hope, our basic scientists and our translational scientists can figure out and develop something that will do that for us so we can get them into remission with chemo and radiation and surgery and then keep them in remission. And maybe it will be something different, but we have to figure out that thing to keep them in remission.
Yeah. So how do you advocate for cancers and healthcare access and delivery? I saw you were talking about the Give Kids a Chance Act.
Yeah, so there are a couple of groups that work on sort of joint advocacy and things like that. So I have been working with the Alliance for Childhood Cancer for several years. It's an alliance of, I think, like maybe 30-ish organizations, parent groups, advocacy groups, professional organizations who set legislative priorities, and then we advocate for those on the federal level. There's also people working on state level stuff, but I think for these rare diseases like rhabdomyosarcoma, osteosarcoma, childhood cancer in general, we really need federal support so that we can make sure that the healthcare system, which is intimately entwined with our government, even though we don't have a government healthcare system, our government and our healthcare system are so intertwined that they have to work together. And so we have been working for several years to, number one, make sure that researchers have enough money to write grants for and request money for promising projects. If you don't have any money, research doesn't happen. So we've been working on that. We've been working on trying to make sure that people that are working with the data, so not necessarily at the bench in the science, but making sure that the data is harmonized and people can access that data in a way to do other types of research. So that's through our Childhood Cancer Data Initiative, and that's been funded for quite some time. And then it's like these other tricky things of like, the FDA a couple of years ago said that if a drug company had a drug that they were getting approved, they had to do pediatric studies. And that's been the law for a while, but some of the drug companies were not doing those pediatric studies, but the FDA didn't have the authority to sanction them or to fine them if they didn't do it. So they were like, yeah, we know we're supposed to do pediatric studies, but we just didn't. And there was no repercussion for that. So we just passed legislation that gives the FDA the authority to say, hey, you didn't do your pediatric study in this drug, and you're supposed to by law. So we've been advocating for things like that. The Give Kids a Chance Act had multiple provisions in it. That's one of them. Medicaid in our country is a little convoluted and it's run by the states. It's federal money that goes to the states and then is distributed. I live in Minnesota. There's a lot of rural population around where I live. I think even where I live is maybe considered like a city, but it's very tiny. And so if somebody in Iowa needs my care or needs proton radiation or something, we have to get the Medicaid systems to work together. And it used to be like super onerous, and every state is different. And so part of that Give Kids a Chance Act was kind of reducing just that like paperwork. Like, why is it so hard if I have the paperwork to say that I am approved by North Dakota and Minnesota Medicaid? Why can't Iowa just accept that? Because clearly I'm in good standing with these other two states. So just trying to reduce some of the bureaucracy of it, which most people don't think about, but children with childhood cancer have a qualifying disease that even if you wouldn't normally meet the income requirements for Medicaid, they meet the sort of complexity requirements for having at least secondary Medicaid. So a lot of our patients are on Medicaid just because of the complexity of what they're dealing with. So that's been super rewarding to kind of work on that on a national level, but certainly it hasn't been me just doing it for sure. Like this has taken like a powerhouse of people to come together and to continue to kind of keep pushing and asking and pushing and asking. And I'm super glad that it finally went through.
Yeah, that's great. And then my last question is about your blog. I read a few posts, but would you say it's mainly a resource for parents or anyone interested in cancer or healthcare?
Yeah, I guess it could be for anyone. I started that, and it's kind of been stop and go. I started it back in 2018. I think I had finally gotten to a point in my career, um, where I noticed I was sort of answering the same questions over and over and over again, which is totally fine. But I think some people learn differently. And I don't learn very well from listening to things. Like I can't listen to podcasts and like learn from it. That's just not how I learn. I learn by reading. And so I wanted to put some of those thoughts onto paper so that if people wanted to have access to it at a time that wasn't, during clinic hours, they would have access to it. And I wanted to tell people that, I think there's a growing distrust with the medical field and medical professionals, and that predated COVID. Um, but I wanted people to know that, like, we're just people trying to take care of people, and this is what I know about medicine. And I don't know everything about medicine, and I probably don't know everything about childhood cancer. Like, and that's okay. We're just people who are trying very, very hard to take care of people when they need us. And there is no ulterior motive at all. And so I really wanted people to know that, I'm just a girl who likes science and likes helping people. And I'm not in it for anything other than that. And so I felt like kind of opening myself up to the world would help potentially portray that. It's tricky. It's tricky with social media and the internet. But I do think it is helpful in some ways because medicine used to be very closed off and it used to be um, not a bi-directional conversation. And now it is a bi-directional conversation of what do you want for your child? What do you want for yourself? What are your goals? How can we meet them? This is what I think, but does that work with what you're thinking? And sometimes those decisions can't be, those preferences can't always be changed. We can't always do everything that people want, just for safety and regulations and things like that. But it's more of a conversation than you come in, I tell you what to do, you go home. I think those days are over. And I think that's a good thing. So I just started writing down what I was talking about in the clinic and if people find it helpful, great. And if they don't, that's okay. It's also helpful for me to sort of organize my thoughts some ways. So yeah, it's kind of gone through different phases of more writing versus other social media avenues and other things. But yeah, it's been a little bit of a interesting journey.
Yeah. All right, that's the end of our questions. Thank you so much for your time.